Hello everyone, and welcome to a weekly podcast brought to you by VJOncology. This week, we'll be covering our highlights from the ESMO GI 2026 meeting, which we attended live in Munich. This content is available on the GI Cancer channel on VJOncology, an independent medical education platform, which is supported by Gilead Sciences, Silvio, and Revolution Medicines, Silvio. Supporters have no influence over the production of content. The levels of sponsorship listed are reflective of the amount of funding given. To begin, Teresa Macarulla from Vall University Hospital in Barcelona describes preliminary safety and efficacy findings from the phase 1 study of zoldonrasib and daraxonrasib in patients with previously treated KRAS G12D-mutated metastatic pancreatic ductal carcinoma.
This trial assessed the efficacy and the safety of this combination, zoldonrasib and daraxonrasib, in second-line or beyond metastatic pancreatic cancer. It's very interesting because, again, zoldonrasib didn't add toxicity to the toxicity that is reported with daraxonrasib, and also there is a clear synergistic effect between both drugs. They reported a very, very promising response rate in second and in third line. Also, this activity is very favorable if you compare with the data reported with daraxonrasib as a monotherapy strategy.
She also discusses data from another phase 1-2 study of zoldonrasib with chemotherapy as first-line treatment for KRAS G12D mutated metastatic pancreatic ductal adenocarcinoma.
This is a very important and interesting abstract in which we can see the safety of this combination, and the conclusion is that zoldonrasib didn't add toxicity to the standard chemotherapy, modified FOLFIRINOX or gemcitabine, but we can see a clear synergistic effect between zoldonrasib and chemotherapy, with the response rates really promising in this setting.
Following on, Giulia Martini from Naples explores results from the CAPRA-2 genome trial, which evaluated plasma ctDNA comprehensive genomic profiling to guide sequential cetuximab-based therapy in RAS BRAF wild-type microsatellite stable metastatic colorectal cancer.
Yes, CAPRA-2 GOIM trial is a phase 2 multicentric study that investigates the efficacy of an anti-EGFR treatment during 3 lines in metastatic colorectal cancer. It is a biomarker-driven study because liquid biopsy guides the treatment, so patients receive a first line with FOLFIRI plus cetuximab, and then a second line ctDNA for RAS BRAF wild-type metastatic colorectal cancer patients guides treatment, so they receive FOLFOX plus cetuximab, while patients with mutation in RAS and BRAF receive FOLFOX plus bevacizumab. And also in third line, we have the selection for RAS and BRAF mutant that received trifluridine tipiracil plus bev, or means bev and regorafenib, or they receive irinotecan plus cetuximab if RAS BRAF wild type for ctDNA. The results that I presented yesterday was the efficacy results of first line in 182 patients. Overall response rate, that was the primary endpoint of the study, showed a very good response rate in the intention to treat population of about 74% that reached 78% in the negative hyperselected patients. These kind of patients are the ones that do not retain any mutation of 14 genes that are selected with the ctDNA that confer resistance to anti-EGFR. Similarly, PFS was 12.2 months in first line and reached 13 months in patients that are negative hyperselected and also RAS BRAF wild type, more than 13 months, reaching 13.8 months. I present also the data of second line with the FOLFOX plus cetuximab in patients with RAS BRAF wild type tumor that were 75 patients. Also in this case, our response rate was better in the hyperselected negative patients compared to the positive hyperselected, and median progression-free survival was 7.6 months. That was quite good for a second-line treatment in metastatic colorectal cancer with negative hyperselected patient that reached 8.3 months.
Next up, Lorenza Rimassa from Milan describes results from a phase 2 trial for regorafenib in pre-treated patients with FGFR2 fusion or rearrangement positive advanced intrahepatic cholangiocarcinoma.
This is a Chinese trial that enrolled patients with FGFR2 gene fusions, patients with cholangiocarcinoma previously treated. And the drug is a new FGFR inhibitor. There are already two drugs on the market, Hunimed and Futibati. This is a new one. The results are very similar to the results that we have with the two available drugs, but this is a different population because it's a Chinese population. And this is an important study because in patients with cholangiocarcinoma, we need more drugs. This patient population with bad prognosis, even if during recent years we had improvement with chemoimmunotherapy in first line, targeted agents in second and following lines. But this is, again, an important study. Of course, it's an early phase trial, so we need to confirm these results, but this could be a new option, especially for Chinese patients, maybe if it would be tested in a broader population, that can be a new option for a broader population, yes, of patients.
She also comments on a phase 1 study of futibatinib with zimberelimab and chemotherapy as first-line treatment for unresectable advanced and metastatic biliary tract cancer.
This is another important trial run in Japan, and it's a new concept. So it includes patients, unselected patients in first line treated with chemoimmunotherapy. That is the standard of care. The immunotherapy is a new agent, but overall chemoimmunotherapy is the standard of care. Adding futibatinib, that is an FGFR inhibitor, but in this case, it's not used an FGFR inhibitor, but is used as agent modulating the tumor microenvironment. And so that's the background, that the hypothesis. And so it can improve the efficacy of chemotherapy and immunotherapy without adding toxicity. Again, this is a preliminary study, an early phase study. The results are very, very promising and compare very well with the results already available with chemoimmunotherapy. So we will see if this can become a new option. And the phase 3 trial has been planned. So enrolling patients worldwide. And once again, we need more data, we need more results. But if the phase 3 trial will confirm these results, that will be a new option for our patients.
We also have Kohei Shitara from the National Cancer Center Hospital East of Japan, who explores health-related quality of life outcomes from the Horizon GE801 trial and HER2-positive advanced gastroesophageal adenocarcinoma.
We reported the QA result and patient-reported outcomes from Horizon GE801 trial, which evaluated zanidatamab plus chemotherapy with or without tislelizumab compared with trastuzumab plus chemotherapy in HER2-positive population. The primary analysis was already reported, and it showed improved PFS with both zanidatamab-containing regimen, and OS improvement was also confirmed with triplet regimen with zanidatamab, tislelizumab, and chemotherapy. It also showed the increased incidence of diarrhea or other GI toxicity. So it is quite important for us to assess the patient-reported outcome, how this kind of toxicity has impact on patient quality of life. And actually, this was one of the secondary endpoints, and we collected the questionnaire every cycle until 12 cycles, then every 2 cycles afterward. And the overall completion rate of the questionnaire was quite high, so this analysis was supported by robust and longitudinal patient-reported data. And actually, overall patient-reported data and quality of life were well preserved during treatment with zanidatamab. There's some initial decline of scores of QOL with zanidatamab-treated patient and some increase with trastuzumab-treated patient, but actual difference was relatively small and stayed well below the minimal or smallest reportable change, corresponding to one response level difference in the questionnaire. And importantly, this overall quality of life were improved, especially after cycle 8, corresponding to 5 to 6 months after the beginning of study treatment. And this is also soon after the opportunity to discontinue backbone chemotherapy by investigator judgment. And also, regarding the symptom scales, we see the difference in diarrhea and anorexia at cycle 8 as expected. But looking at time course of diarrhea, initial worsening was observed across treatment group, but it gradually improved over time with small difference after follow-up. And the same is true for anorexia. The actual difference after follow-up is quite small. Regarding functional domain, physical function was well preserved among patients treated with both zanidatamab and trastuzumab, and approximately 70% patients maintained or improved physical function during the study treatment. So overall, this study showed significant improvement of PFS and OS with zanidatamab-containing regimen without meaningful deterioration of health-related quality of life or patient-reported outcome. And most of the function and symptom domain are comparable across treatment groups, with a slightly worsening of diarrhea at early time point, which is consistent with the safety profile of zanidatamab, and the physical function was well preserved. So overall, these results support the use of zanidatamab-containing regimen as a new potential standard of care for this population.
He also provides us updates on HER2-targeted agents in metastatic esophageal gastric cancer.
Until now, we only have 2 agents for HER2-positive disease, including trastuzumab and T-DXd, and this is less than breast cancer treatment. And first, we have an intratumoral heterogeneity in gastric cancer tumors. It is quite common phenomenon in gastric cancer compared with breast cancer. So as a result, around half of patients show reduction of HER2 after trastuzumab. This is one unique aspect of gastric cancer. And also, heterodyma between VJFR and HER2 is important for incomplete HER2 blockade by trastuzumab. So overcome this VJFR HER2 heterodyma is also another important aspect. Also, activation of downstream pathway by HER2 mutation or downstream pathway mutation, as well as unrelated pathway alteration like MET, are all relevant resistance mechanisms. So how we can overcome this resistance mechanism? First, we can use combination with chemotherapy and ADC agent with bystander effect to overcome intratumoral heterogeneity. And one of the exciting areas is bispecific agent like zanidatamab or one Chinese similar agent. And also, combination with immunotherapy also showed activity in phenotype 11. So to combine with the newer types of immunotherapy is also interesting. And combination with HER2 TKI or some other pathway like MET are also interesting. So first, zanidatamab already shows a benefit in global phase 3 trial, and hopefully it may change the standard of care in the near future. Also, the diarrhea management is required, but it could be the preferred first-line option because of the large magnitude of benefit. And this is also important for EGFR and HER2 heterodymer formation because zanidatamab can block heterodymer formation because of the HER2 clustering. And same could be true for HLX22 as a new HER2 agent as a monoclonal antibody with different epitope for binding compared with trastuzumab, although it is bind within the same domain. This combination with HLX22 and the trastuzumab induces rapid internalization of the homodimer or heterodymer with EGFR, and it showed quite encouraging activity in previous Chinese study, and currently phase 3 study is ongoing. Also, ADC like T-DXd combined with a checkpoint inhibitor with other cytotoxic chemotherapy also showed some promise in previous phase 2 study, and these combinations are being tested in global phase 3 like DGO5 and ultimate study. And also other new types of combination like T-DXd with zongertinib as a HER2 TKI, EGFR targeted agent, or newer mild checkpoint inhibitor are being tested. Also new types of ADC such as bispecific ADC or ADC with new payload or bispecific payload have been extensively tested. But I think not only these new agents, but also more understanding of tumor biology should be also important for us to improve our patient outcome. So, for example, more stratification by biomarkers, reassessment of biology through treatment period, and more understanding of resistance mechanism of each component. So maybe we need more research, but overall, we have a quite promising HER2-targeted agent and ongoing research, which hopefully improve our patient outcome.
Finally, Silvio Ken Garattini from Udine, Italy, discusses how the EMERALD-3 and EMERALD-1 trials reshape taste strategies in hepatocellular carcinoma.
Today, at the proffer paper session of ESMO GI 2026, we saw the data of 2 clinical trials directed to the treatment of HCC hepatocellular carcinoma. Those trials are the EMERALD-3 trial and the EMERALD-1 trial. So let's talk about the EMERALD-3 trial. This was a phase 3 clinical trial in which patients with embolization-eligible HCC could be randomized to a steroid regimen plus lenvatinib plus TACE, or steroid regimen plus TACE, or again, randomized to the standard TACE alone. What was previously demonstrated at ASCO 2026 was an advantage in terms of progression-free survival for both the experimental treatments. What we saw today was an update in terms of progression-free survival evaluated by the RECIST criteria 1.1 by BICR, so a central review, and using also the modified RECIST criteria. Again, we had a confirmation that progression-free survival was in favor of the two experimental treatments, but overall survival data are still pending. Then we had the data on EMERALD-1 trial, which is an older phase 3 clinical trial in which the same population of embolization-eligible patients was randomized either to receive the durvalumab, bevacizumab, and TACE, or to receive durvalumab and TACE, or TACE alone. We had previous data which were presented with a positive progression-free survival for the arm including bevacizumab. At this time, overall survival data were presented. Unfortunately, overall survival data were negative, posing some question about the use of progression-free survival as a surrogate endpoint for overall survival. All in all, those results probably are still pending of overall survival confirmation, but still STRIDE plus or minus lenvatinib could be a good option to be added to TACE, especially in patients with an intermediate risk ACC.
He additionally comments on his own findings from the ERFORT study, a retrospective multi-center analysis identifying clinical and pathological predictors of early recurrence after perioperative chemotherapy in resectable gastric and gastroesophageal junction cancer.
So the ERFORT study is a multi-center Italian retrospective study in which we studied a cohort of 168 patients in order to look at those factors which are linked to an early recurrence, let's say a recurrence within 9 months from the termination of FLOT. And from this study, we found that there are some factors which are linked with early recurrence and 9 months short recurrence-free survival. And those factors were then analyzed in a prognostic score, which was able to sort out a patient with a low risk of progression, an intermediate risk of progression, and high risk of progression. In our study, we found out that on 168 patients, there were, in univariate and multivariate analysis, there were those factors who were associated with a short recurrence-free survival. And in fact, patients with a high baseline SIA with a clinical stage T4 stage at the beginning of the treatment and ECO-PS performance status of 2 were linked with a worse recurrence-free survival, while patients who achieved a good response in terms of nodal response and who could complete 8 cycles of FLOT were with a good prognosis. And actually, we derived a prognostic score which could be able to distinguish people who have low risk features, intermediate risk features, and high risk features for recurrence. Yes, of course, we are talking about a small multi-center Italian retrospective study, so we are planning also to have a validation cohort, and those could integrate also data on the treatment with durvalumab and FLOT. And those factors could be useful in a clinical practice in order to individuate those patients who we should care of in terms of a higher risk of recurrence.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.